Good afternoon, and welcome to HealthSystemCIO.com All-Stars panel, Learning from Payers About Population Health Management, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Geneia. Just some housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are hosting a tweet chat at the same time as this event, which is hosted by our Managing Editor and Director of Social Media, Kate Gamble. So you can participate in a separate browser or on your phone by using the hashtag HCSCIO chat, or if you want to just view the tweet chat, you can do that in the media viewer panel on the right-hand side of your screen. We're also going to do a couple of polls today, so that'll be in your polling panel on the right, and we will have the Q&A panel going today. That's where you enter your questions when they occur to you. You can type them in and send them in at any time, and leave the default set to all panelists. We'll take those later in the program, but again, you can send them in as they occur to you. And you see the URL to download the deck on your screen, and we also have a shortened URL at the bottom of our slides, and it will go out in the chat box. So send plenty of chances to get that URL. There's our agenda. So you see how we're going to spend our time today. We're going to hear first, we're going to get an introduction from Jeff Cribbs, Research Director at Gartner, who's going to set the stage for us on our conversation. Then we're going to have our panel discussion, and we're featuring Howard Underwood, Dr. Howard Underwood, FSA, VP, and Actuary Enterprise Clinical Analytics with HCSC, which is the BCBS of Illinois, Texas, Montana, New Mexico, and Oklahoma. And as I mentioned, we'll have Jeff Cribbs, Research Director at Gartner, and we'll be joined by Mark Caron, who's the CEO of Geneia. And then we'll get to your questions. So without further delay, I want to turn it over to Jeff Cribbs, who's going to give us some table setting. Jeff?
Great, thanks, Anthony. Thanks to my hosts. I appreciate the opportunity to be talking about this issue, which is one I've been looking at for a while and find very interesting. So I've been at Gartner just about 5 years now, and you know, I come from a payer care management population health background. And so this question has been on my mind since I joined, which is, what exactly is the nature of the relationship between population health management, as it has been known on the payer side for a decade or more, and some of the recent moves on the provider side. And so one of the things I think at a high level that has been interesting in the 5 years I've been looking at this has been how it seems that the conversation around population health among providers is following a very similar but compressed evolution as what we saw over the course of a decade or more on the payer side. For example, if you were to go to the vendor floor at HIMSS or other big HIT events, and you were to sort of think of the messaging and sort of use that messaging as a proxy for what the state of the conversation is, you'd see a very similar evolution as what you saw on the payer side. First, when the providers got their first batch of claims data of their attributed members, and they thought of population health as sort of a data management and reporting problem. So they had claims from the government, and for their commercial contracts, they wanted more claims data, and they wanted more frequent reporting. They thought of this population health problem as primarily a data management and reporting issue. And then over the course of the next year or so, you saw that evolve into say, well, it's not enough to have data or even reporting. This is an analytics problem. This is a sophisticated population health analytics problem. Then you realize at the end of analytics, it's not just about being able to identify and enumerate a group of people and opportunities. It's a workflow problem. Once you form that queue, you need to know what to do with them in sort of a systematized way. So you start to talk about the workflow of care management. And then finally, I think in most recent years, you hear the conversation shifting to it really being an engagement problem, that ultimately the kinds of interventions that we're doing in our population health efforts are more engagement, more relationship interventions than they are, in fact, clinical interventions. And that sort of takes me to what I'm going to walk just quickly through just 5 lessons, actually. This comes from a longer list that I've developed over the course of my research here. But I'll briefly just touch on 5. So first lesson is if you can't engage members, nothing else you do matters. So over the course of the time payers have been looking at this problem, we've done much better at, for example, segmenting populations based on their claims data and inferring health states from claims data. And we've put a lot of money into systems to improve workflow and to scale communications efforts and things like that. To the extent that that has not improved engagement, none of it actually matters. So I think the first lesson learned from payer experience is around engagement. Now the question is, what's the takeaway on the provider side? I mean, one of the great hopes, it seems to me, of provider-directed population health is their closer proximity to the patient and their closer proximity to the actual clinical health state of that patient. So we're seeing, just anecdotally, it of course depends on a wide variety of factors, but that initial engagement effort from a provider-directed population health program is something like 4 times as likely to result in an engaged member. But of course, it's not just about that initial engagement, and I would say lesson number 2 from the payer side has been trust is a key to member engagement, and if you lose it, it's gone. Now, what's the takeaway from the provider side? So we're counting on the trust of provider organizations to give us this boost in engagement, but we can't take that for granted. Population health improvement is about persistence. And so as the individuals start to receive phone calls and proactive outreach and efforts to engage, they're going to realize that something has changed. And it's important in those efforts to always be reminding the patient what the value is to the patient. So I think lesson number 2 is around keeping that trust that the providers will have out of the gate. Incentives, so over the course of a decade or so, payers started to look at incentives, and it started out as tote bags and rewards and various things for participation or for achieving certain milestones in population health management programs. And it got into gift cards and then actually rather large sums of money that were given to people for completing various educational modules, having a conversation with a nurse, or using online tools. And what the idea there was that we would hook them with some sort of incentive, and that they would find in that engagement such value, and they would start tracking their own health, and they would become sort of voluntary participants in the program, and ideally even recommend it to their peers and to their family. It turned out that sounds almost a little bit naive today, knowing what we know. But members respond to incentives precisely. They do exactly what they are incentivized to do. The good news is that we know that incentives work. The bad news is that they don't work in their sort of halo effect, and any idea of a halo effect. So the mechanisms and the regulations around incentives are slightly different for providers, sometimes significantly different, and we haven't seen the same level of incentives yet. I expect that as risk continues to shift and we do a better job of establishing the value of engagement with provider-directed pop health, we will be talking about financial incentives again. The important thing to remember is that you don't get a halo effect from those incentives. Just 2 more, application integration. So in the context of payer enterprise architecture, and I won't get too technical here, but we lose a lot of value for care management, and we add for our businesses a lot of overhead if we don't do a good job of interfacing the applications that surround population health management technology. In the payer context, that means things like call center technology. Payers have really struggled to take advantage of what is a proven way to engage members, which is nailing inbound engagement. When somebody calls with an administrative question and they or someone in their families has a clinical gap that we're trying to address with a population health management program, it has been difficult to connect those things together, and we lose value. And then we also end up setting up a lot of routine maintenance costs for ourselves when we have to be manually or inefficiently transferring data between those applications. On the provider side, those applications will be different. We'll be talking about ERP systems, we'll be talking about enterprise data warehouses, we'll be talking about revenue cycle, electronic medical records, and increasingly we'll be talking about customer relationship management tools, but that same lesson, we believe at Gartner, will continue to be true among the efforts on the provider side. Last one, and this really goes to the value of analytics. We shouldn't underestimate how difficult it originally was to do care management based on claims data. As anybody who has really gone into the weeds on diagnostic codes and some of the inconsistencies you see in claims data, inferring health and inferring disease states and gaps in care is a challenge. One of my former peers here at Gartner used to call it inferential mojo, that your care management analytics needed this inferential mojo to be able to derive health states and value from that. But over time, payers were able to do that, and actually quite consistency. So we started to see fewer false identifications. We restrained ourselves from intervening in places where we weren't sure we had the complete story or were likely to be acting on false information. But what we haven't yet done, and really the state of the art today, is what analytics can tell us what we need to do to change behavior. Behavior change, as we are learning over and over and over again, is a very tricky beast. And that is the state of the art of analytics in population health today. The providers have a much richer clinical data set for one thing, but they will also need to address the behavioral issues and use behavioral analytics to talk about ways to close those gaps. So quickly, I hope that was useful to frame up the conversation, but I'll hand it back to Anthony to get our discussion going.
Excellent, excellent. Well, thank you very much for that, Jeff, and I think it was a great overview to get us going. So now let's get an overview of the organizations that our panelists work for. Howard, can you give us an overview of HCSC, please?
Sure thing, yes. So hi, I'm Howard Underwood here. I'm a VP and Actuary at their Enterprise Clinical Analytics Department. Healthcare Service Corporation is probably the largest health plan you never heard of. We're the nation's largest nonprofit health insurer. We are number 4 when you look at the big 3, i.e. behind United, Aetna, and Anthem. And we're comprised of 5 Blue Cross and Blue Shield plans: Illinois, Texas, Montana, New Mexico, and Oklahoma. And pretty much the way you kind of assess size, one way to assess size is number of lives covered, and we cover about 15 million lives. So we're basically a traditional Blue Cross and Blue Shield plan, but across 5 states, and kind of bring a holistic enterprise direction managing the 5 Blues plans.
Excellent. Mark, let's go with you. Tell us a little bit about Geneia.
Oh, thank you, Anthony. So Geneia is a clinical services and healthcare analytics organization. We combine our clinical delivery, which is over 100 nurses, along with a robust platform of analytics, tied in with additional support components like our Geneia Institute, which is a education, training, consulting organization, and products around things like remote monitoring, remote patient monitoring, et cetera. And we were a wholly owned subsidiary of a Capital Blue Cross in central Pennsylvania. However, Geneia is a national organization headquartered in Harrisburg and also has offices in New Hampshire, Manchester, New Hampshire, and a sales office in Nashville, Tennessee. And we probably have just under 300 employees right now.
Excellent. Jeff, tell us a little bit about your work at Gartner, and a lot of people know Gartner, but just a little bit about what you're doing over there.
Sure. So Gartner, as many of you know, is a research and advisory firm. We specifically focus on technology decisions. So we are trying to help organizations make the best possible technology decisions. We have hundreds and hundreds, something like 800 horizontal analysts covering every specific technology. And then there's a number of us that are focused on certain industries. I sit in one of those groups. I am in healthcare. And so we really focus on advising payer, provider, and life sciences organizations on making the best technology decisions. For that group, I cover population health, consumer engagement, and advanced analytics.
Very good. Thank you, Jeff. All right. I want to start with Howard on this question. What aspects of population health management have payers traditionally excelled at?
Great, yes. So I think Jeff did a great job of kind of highlighting some of the issues, challenges, et cetera. I guess from a payer's perspective, I mean, historically, it's been all about the claims data. I mean, that's kind of been our main currency that's ubiquitous throughout a health plan. So having that expertise around the administrative claims data, really kind of bringing that to the table. So historically, it's been much as what Jeff is describing, risk identification, stratification. So you have the data, you develop the stratification models to identify people, and it really kind of boils down to a member segmentation. So you have various medical management, care outreach programs, case management, disease management, et cetera. So based upon kind of the levers into those programs, you want to segment and stratify your patient population to more closely align up, so you can, better target your investments in population health management. So really, kind of the historical, health plans have been great at kind of leveraging claims data to build these risk stratification models to help with interventions. And I think with kind of that as a background, kind of that central intermediary in healthcare, health plans will continue to be in great position to continue that in the future as more, new data sources come online, such as from EMRs, the meaningful use data, the electronification of that clinical data, along with even other data sources such as, genomic data, pharmacogenomic data, kind of the personalized medicine space, et cetera. So just kind of being that intermediary and kind of leveraging the historical strength in health plans around bringing data together to kind of incorporate those new data sources.
Excellent. Now, Mark, I believe you've had a past life in the payer space as CIO. Tell us a little bit about that and your thoughts on what aspects of pop health management payers have excelled at.
Sure. So I've had actually quite a few years as CIO for payer, but also as Chief Technology Officer for a large hospital system. So it's interesting to have seen both sides of this, if you will. Mm-hmm. Payers have always done just a great job of understanding the risk, to Howard's point, and stratifying and IDing, segmenting, particular disease states by population. And really what payers always had the opportunity to do was to bring the longitudinal view, horizontal view, if you will, of a patient, where, and what I mean by that is a hospital or provider doesn't have all the data, right? So they might have the information from you. They might be in a delivery system where if there is interconnected EHR, they might see something at another physical location. But if you were on vacation in Hawaii and you had services there, they would not know that. So payers notoriously have been good about having all that claims data to be able to get a picture of you. Now, the problem with that, and I know we'll get to that question a little later, is it was somewhat full of holes. And to the accuracy of it, it always tied back to how well coding was done to really reflect somebody's services going forward. And then, of course, coding gaps. So if you had a physician that didn't properly code on a particularly Medicare on the beginning of a new year, excuse me, somebody that was a CHF patient a few years ago and may not have had any additional follow-up, that would fall off, so that produced some gaps. I think, the traditional care management programs in the past from payers had been all pretty much that was available, and it was mostly telephonic. And this, I think we'll talk a little bit more about patient engagement and the evolving need around these newer programs and newer approaches, but those are typically the things that I think payers have done well.
Excellent. Jeff, I'd like to get your thoughts on the question.
Yeah, I think those are the two big points. I would add to this. Payers are systematic thinkers, right? They're process-oriented thinkers. They think about processing claims, and they took that approach with care management. And that actually has some really great benefits. One thing is to say that they early on recognized that there was a systemness to population health management, that you needed it to be a system that worked. And you needed to, apply evidence-based guidelines and repeat it. That means that if, one particular care manager discovered a particularly good way to interact with a diabetic patient, or an order for the assessments, or a motivational interviewing technique, there was a mechanism to scale that and say that is the new best practice for dealing with this. So you systematize and standardize some of the best practices to make a system out of this thing. That becomes really important when you're trying to do really, difficult things like prioritize care management resources. If you don't have any systemness to your population health management program, you're basically unable to do that. So that, from a process point of view, that's a strong point. And I think that because they have that process point of view, they are also relatively early to understand the opportunities and needs for technology support. So we've seen, we're entering our third generation of care management workflow applications, right? But early on in the industry, there was workflow support for care managers. And you see, outside of payer care management programs, you see all kinds of work happening with no systemness and no technology support. So I think those are two areas that payers have done quite well.
Very good. Mark, as you mentioned, we were going to touch on the other aspect for both payers and providers, but let's talk about what payers have struggled with. You want to start off, Mark?
Sure. Thank you, Anthony. So, I think Jeff had talked earlier on member engagement, and I think that's been one of the real challenges in the industry, and I still think to a great extent is the holy grail, if you will, to overcome, particularly the at-risk population, and more particularly as you look at the Affordable Care Act and the high-risk members that have come into the system, and having access to them and outreaching to them and getting them engaged early has been, I think, a challenge to educate people. So, that to me is still one of the issues that we have to overcome. The other piece is the data, right? So while claims data is good, we've had limited data sets that we've run risk adjustment or assessments on to really start identifying early risk or rising risk factors around patients. And I think the tools of yesteryear have been a limiting factor to that. So being able to take in psychographic data, behavioral health data, all the different data sets that are out there to learn more about people in the past has been very limited. Going forward, that's absolutely a requirement. So I truly believe that. And then Jeff had mentioned, you know, integrating care management activities. I think that's key, particularly now as you're getting into these risk arrangements and shifting risk and building ACOs and transitional care models where the delivery system may take some of the function and they're partnering with a health plan to manage that population. Having an integrated capability where the health system care team can see the activities of the health plan care team, making it that one care team, to me has been a real challenge in the past that we have to solve for to be successful moving towards this value-based care.
Howard, do you agree member engagement has been one of the struggles for payers?
Oh yeah, member engagement would be a great place to focus. I mean, I think taking a step back, even bigger picture, it's just the operationalization of population health management. I've been in places and I've seen, I mean, there seems to be focus around identifying the most accurate predictive model that you can identify the risk. But then it really kind of boils down to the integration, the operationalization of that newfound knowledge. And that's one of the things you have to kind of balance operationally. Is like if you have a third-party vendor coming in versus building it within the buy versus build decision, it isn't always so easy just to take an external vendor and incorporate them. You really need to kind of be thinking strategically on how the data fits into the workflow. I mean, I was in a place where they had models in place, but they weren't really being used, and it required a lot of kind of reaching out to the care management staff, understanding their workflow so that it wouldn't detract from their usual workflow taking care of patients, that the models, the information coming from the data within the payer would be kind of user-friendly in the operational workflow. And kind of along those lines, just the issue of false positive, when we've talked about claims data being great, it's ubiquitous, but then it's also claims data. Some providers don't necessarily put as much effort into the accuracy of claims data. So claims data is wrought with challenges, and that can result in false positives, i.e., like any screening test, say, for colon cancer, same idea. You identify an opportunity, identify a patient for an intervention, but at the end of the day, it's a false positive, i.e., they weren't really an actionable or an appropriately identified person. And then also in that kind of a member engagement, also just identifying new data and getting that in-house. Claims data is easy, it's in the health plan, it's what's used to adjudicate claims, but some of the additional challenges are around the non-traditional data, trying to capture that lifestyle behavioral aspect, and also even outcomes data, as was evidenced when HEDIS first went live, and a lot of the measures were process kind of measures, and then they started branching out more into the outcomes measures, such as the hemoglobin A1C levels after, for diabetic management. It really has to, again, fit into the operations of a health plan. When HEDIS came out and said, you needed to, track hemoglobin A1Cs, then operationally within the health plan, they had to, make the investment in getting that data, getting it structured, getting it in place so that it's reusable. So it's an additional investment as opposed to kind of the usual claims data just in the course of operations. And that's really the opportunity in population health. We had the claims data, so it's kind of the predictive model relative risk score, high to low to stratify patients. To further refine the problem of false positives, looking at gaps in care to help focus the intervention, but then, as Jeff was describing, getting that whole member engagement. I mean, are there various aspects and lifestyles, things we can kind of bring into more tailored from, say, a consumer's perspective to better engage them, to get them on board, to do the most appropriate clinical things.
Very good. All right. Thank you, Howard. Now we're going to go with our first poll. This poll is anonymous, so don't worry about it getting out there. You should see the poll in front of you now in your right-hand side of your screen, and you can go ahead and begin to answer it. How prepared do you think your organization is to go at risk? And you see your selections, obviously. We're just trying to get a general feeling. Don't worry about being overly scientific on this one. So we'll come back. Go ahead and answer that, and we'll come back to it. Howard, I want to stick with you here. Can you talk about some of the specific things that your organization has been doing to manage population health, and do you think these particular strategies could be copied on the provider side?
Sure, yeah, so it all kind of goes back to the Pareto rule, the 20% that generates 80%. So a lot of population health, we're looking to identify the 20% of patients, members, insureds that result in 80% of the cost. So, and that's how we align up our various interventions around case management, disease management, et cetera. Health plans have been doing a great job over the years at doing that, leveraging the tools of population health. And now, since that aspect has been pretty much commoditized, now looking at the flip side, the 80% of members responsible for 20% of the cost, and that's the opportunity around wellness. So again, developing wellness programs to get people to own their health, to be more proactive and doing healthy behaviors to, have better health outcomes for them, and also, less cost. So, health plans have been successful doing that. And that's where I see the real opportunity, in the emerging provider-payer convergence, focusing around value-based care. CMS just came out with the MACRA ruling recently, and I've been told that MACRA is to providers what healthcare reform were to payers. Tremendous opportunity, really, in focusing energies around value-based care, such as CMS's Burwell has targeted 50% of CMS's activity is going to be focusing around value-based care kinds of reimbursements, contracts, et cetera, by 2020. With what a health plan has done around population health, and then partnering with providers in this new shared risk alternative payment model kind of a space, it's all about aligning the incentives, all focusing around the patient-centered care, and then working collaboratively and having those risk sharing, the shared savings kind of a models, so it's a win-win throughout the value chain.
Excellent. All right, let's take a look at our poll results, and you should see in front of you that we've got 50% of our respondents answered at the 25% level, and 17% are at the 50% level. So most are under 50%, let's say. Jeff, what are your thoughts on those results? Obviously not scientific, but most are under 50%.
Yeah, I would say, very interesting, but I think, representative of the conversations that we're pretty regularly having with both on the IT side, informatics side of providers, as well as on the business and clinical side. And I think that's, when people are candid about their readiness to handle risk, I think that's the kind of results that you see. Yeah.
Yeah. So a lot of work to be done. I think that's what we're saying. Okay, Mark. And we mentioned you were a CIO and a CTO in the past. Talk a little bit about your work, your experiences. What worked around pop health management and what didn't?
Well, I think the things we talked about earlier, I mentioned were things that worked. The real question is, how well did they work? My argument would be that we as a nation have probably spent billions of dollars at least health, wellness, all of these programs, and have not seen the returns. And so why has that been? probably because of the means that we approached it in not just the care management, but the accuracy of the information provided to them and the incentives tied back to both the patient member and the quality components that had some sort of a value tied to them with respect to some risk arrangement or gain share type relationship. So I think in the past we were minimally to maybe moderately successful, if that makes any sense, but those were not the foundational things that we need to get to shift towards a value-based care delivery system and collaborative model with the payers. The advancing tool sets, and part of the other issue that I really didn't talk about was if you look at all the tools that payers had, they're very disparate. So, Actuary might have used one tool to run some things, the network management team ran tools to do another thing, the medical management team might have run another tool to identify gaps in care. None of these things were tied together or sufficient. So going forward, what was really needed is to really take tools and contemporize them. The other piece of it that we didn't really mention a lot about is the payer's ability to work with the employer group to create new benefit plans and incentives for member patients to start playing in this and taking accountability as an individual. And I think we're seeing more and more employers, particularly as employers are shifting to taking on risks themselves. The insured market has shifted pretty heavily in different parts of the country towards, I think it's probably about 60% or more now are in, sort of administrative services, ASO type models. And so those employers are really seeing those increases and wanting to take a much more active role in creating incentives for their employees. So, I think it's great to look in the past, but I think going forward, the problem or the challenge is substantially different. And the substantially different is two pieces. One, the risk shift to the payer, from the payer to the provider, which I'm not surprised by those poll numbers, by the way. That's what I see in the market, and that's what we've experienced in many of the ACOs that we've put together. It's just a slow adoption rate for that. And so I think putting all of these pieces together, it's what do we really need to be successful going forward? And I think that many of the tools of the past don't solve for the challenge that we have before us.
Very good, very good. As I mentioned, if anybody has a question, go ahead, type it into the Q&A box and leave the default set to all panelists. Thank you for that, Mark. Jeff, let's go with you on this. Based on the different and unique position of providers, what strengths do they bring to the table when embarking on population health management and taking on risk?
Yeah, I mentioned a little bit of this in the intro, but it bears repeating. The trust of patients. So, the unique perch of the physician-patient relationship is, we see it in the data. We see it in all the surveys. It is distinctly different than what we've been trying to do from the payer side. I think, and this is a little bit, a later development even for hospital systems, but, we are getting a level of outside-in thinking having to do with patient experience, patient advocacy. So Gartner recently did a poll of leading CMIOs, Chief Medical Information Officers at leading health systems, and found that more than, I believe the number was 61%, now have a senior leader that's in charge that owns patient experience and patient engagement initiatives. That is significantly different than what we had 5 years ago, and it will engender in these organizations a kind of sensitivity to the needs of the patient, and that I think will even enhance it will enhance that trusted relationship that's already there with a more thoughtful treatment of the full experience of care, which means, the administrative hassles that get in the way of what you're trying to do in care management. So I'd say those two things, trust and outside-in thinking.
Very good, very good. Howard, I wonder what your thoughts are on this. I know you're at the payers, but what, for you to just theorize, other than being new to the game, what weaknesses do you think providers inherently have when tackling pop health management?
Yes, I think it's the skill set in the organization, with meaningful use and healthcare reform, ACA, et cetera. It really kind of turbocharged the collection of clinical data out of the EMRs, kind of laying down the piping or the infrastructure to really kind of capture that data. But then now that you've got all this data, so what? So it's really, I've been seeing more emergence of chief analytic officers and even actuaries coming into the provider organizations to kind of bring that deeper analytical way to kind of leverage that data to improve care in real time. And then also, I guess just in, preparing that data, the health plans, have been in this space for a long time, but for the providers, it's kind of a new, like I was saying, a new skill set, more robust information systems, enterprise data warehouses. So really kind of, further to kind of scale up the information collection process, et cetera, kind of achieving scale to really get down, to some of the small end issues. I mean, as you kind of start drilling down into data, you always, get into the small end size, and you can't have statistically credible results. So really kind of turbocharging the data collection. And prime example is the recent emergence of ICD-10, the replacement for ICD-9. I think it nearly tenfolded the number of codes going from ICD-9 to ICD-10. So you think, okay, that's great, it's additional specificity, but then with additional specificity, your cell sizes are getting smaller too. So just kind of bringing that analytical mindset to tap into these new data sources, to feed it into population health, to again, to identify, really kind of micro-segmented patient characteristics that would influence and identify behavioral aspects to kind of plug that into the population health delivery chain.
Very good, very good. Okay, we have an audience question that has come in. Regarding patient trust, what is the most important factor, cost, quality, or other? Mark, what are your thoughts?
Well, I think quality is a key thing, but also it's pretty amazing that many individuals really have not been aware of what things cost in healthcare for decades. And so I think now with the high deductible plans and all of these things, people are getting much more educated. And I think people trade off some cost of quality, but it's really the trust that they want to build, that their physician is their trusted advisor. And, even though the health plans play a big role in that, in providing some of the benefit products, a consumer typically will take the advice of a provider. So I think they really want to be able to see transparently what is the quality and what is the cost. And as more and more transparent tools come out and data is available to the marketplace and the shift to consumerism continues, I think you're seeing people become much more savvy in questioning why a physician might, why an MRI might cost $700 here and $1,000 there at a different location. What's the quality difference, and doing that trade-off themselves. So I really think it's still that value equation.
Jeff, thoughts on patient trust and the most important factor?
Yeah, to me, where if you look in the context of studies of things like shared decision making, or sort of breaking away from things like the paternalistic model of medicine, I think that the number one thing that patients are saying to us and saying in studies and focus groups is, I need to know that you are aligning to my goals. So that whatever, intervention we're doing, whatever point of contact we have, and this is true on both the payer and the provider side, that the point is to deliver value to you. that, you know, our interests, whatever they may be, are taking the back seat to whatever we're trying to do for you. To the extent that we can put that up front and demonstrate that to people, we keep their trust. To the extent that we expose first other motivations for doing that, I think we risk losing that trust.
Very good. Howard, thoughts on patient trust?
Yeah, I think at the end of the day, it's back to the physician-patient relationship. It's the patient wants to feel like the physician or whomever else in the care delivery chain is listening to them. So, and that kind of gets back to the whole member engagement. So the physician-patient relationship is built upon a relationship back and forth. You know, the patient describes the issue. They want to be heard. They want to be appreciated. And likewise, the physician has to, you know, focus all the energy on the patient to kind of build that, you know, that bidirectional trust. I think it really kind of more fundamentally just kind of goes back to the physician-patient relationship. And what's exciting about population health, we physicians in that can have a scaled up version of that physician-patient relationship. Instead of having that one patient in your exam room, we can be managing populations of, you know, 500, 1,000, it's, you know, even higher, having a bigger impact around healthcare delivery and trust.
Very good. All right, Mark, I want to start with you on this one. And this may be our final question. We'll get everyone to weigh in on it. What tools are needed to go at risk, and what information must be available, and what systems are needed to provide that information? I read a good article a while ago that talked about the granularity of the data that you need to be effective in population health management. Obviously, data quality, which comes from good data governance and, you know, these type of things. But talk a little bit about that issue.
Sure. So, you know, I mentioned several things earlier that, you know, it is about the data and driving the right insights to, you know, the care team, the physician care team, really understanding the patient population, who's at risk, who's, you know, one of the advantages with some of the more contemporizing tools that take in all these additional data sets is understanding sooner who's at in a rising risk category that programs can be put in place. I think fundamentally the challenge for the delivery system and the experience I've had with them is building common clinical workflows in a multi-payer model so they're agnostic of the payer, and then having all those risk arrangements, contracts, quality incentive programs all in one place that they can continually manage to that and understand where their gaps in care are in the care teams and how those new case and disease management programs are being developed and delivered more as a collaborative effort than you know, than ever before. And then really being able to have a full 360-degree view of a patient, so that's why it really needs, from a systemic perspective, a platform that can take in the clinical data, the clinical feeds, you know, your ADTs, so you get transitional care events occurring, CCDs to be able to parse, you know, lab data, all of those things that have been really islands of data, if you will, and bringing it all together and then developing the more advancing algorithms to create those insights for those physicians. And then as that care and those programs are being executed and delivered, being able to close on those HEDIS measures, being able to close those gaps in care, ensuring that the patient's getting the services they need and it being delivered in the quality, you know, that is expected, and to continue building that trust, as both Howard and Jeff had mentioned. So I think this is a topic that can go on for, you know, a longer discussion, but I'll stop so that the other folks can chime in too.
Very good. Howard, do you want to talk about the tools needed? Yes, so from an enterprise risk management perspective, the providers have historically focused around certain aspects of risk, but then through additional, you know, risk sharing, more of the financial, you know, taking on that kind of risk. I think key is a robust enterprise data warehouse that brings all the data in, structures it so that it's readily accessible. And the nice thing about data warehouse is it forces you to deal with some of those data issues up front, inherent in claims data or clinical data, et cetera. to kind of structure the cleansing algorithms one time to fix the data. So then you got that process in place, and then in the future when data comes in, it automatically upgrades and cleanses it. It kind of gives you economies of scale and speed and efficiency. So once you've got the electronic data warehouse, then you really can focus in around knowledge management and decision support tools to query that data, to do business intelligence reporting, advanced analytics, et cetera, to really kind of get to the underlying information that's in that data to understand, what are the potential emerging clusters of healthcare issues to get on that early in the care continuum. Because as they say, an ounce of prevention is worth a pound of cure. That's what we're trying to accomplish, is trying to be proactive, target our limited financial and clinical resources earlier in the disease or condition process, get patients plugged in, and then ultimately result in optimal care delivery.
Excellent. Jeff, any thoughts?
Yeah, just quickly, since, I think great comments on information sharing and then the needs for analytics and getting the insight. The only point I would bring up, in addition to those systems for information sharing and insight, the operational steps will take place in the context of a relationship, and having enterprise architecture that supports relationship management is something that neither payer enterprise architecture or provider enterprise architecture was primarily built to do. And you see that at every layer of the application stack. From the payer side of point of view, simple things like identifying a person who changes a line of business. They go from employer to Medicaid to Medicare to individual. Often we lose 15% of people every time they change a line of business. That is similar on the provider side, managing a relationship on someone who comes in one service line, in the EI, in the ER, or in an ambulatory center, and making sure we can track that relationship across those things. That's at the very bottom of the application stack. But then at the top, we're talking about communication channels, coordinating cadence of communications across different parts of the organization. These are all the systems and architecture of relationship management, which is something we all need to do a better job in healthcare.
Excellent, Jeff. Well, that's about all we had time for today. I want to encourage our audience to take a moment. When you close out your WebEx viewer, you'll be taken to a post-event survey. It will only take you less than a minute to complete, and we'd appreciate it. I want to thank our panel very much, Howard Underwood, Jeff Cribbs, and Mark Caron, and especially thank Geneia for making this event possible today. You'll receive an email when our archive recording has been posted to our YouTube channel. For those of you who hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU. Make sure you let CHIME know you were here. And if you've asked us to do so, we will. To produce a webinar panel discussion on the topic of your choice, please contact Nancy Wilcox. And if you need a certificate of attendance for another CEU program, you can use the final slide in this deck. And of course, you can go to our website to view our upcoming schedule of webinars. So with that, I want to again thank Geneia. I want to thank our panel, our audience, and everybody have a wonderful day. Thank you.
Thank you.